Always has three. Why don't we go ahead and get started? We have some exciting presentations here. This is the uh, mini oral sessions. So we would try to ask you to please stay on time. 8 minutes for the talk and 2 minutes for the discussion, and then another 2 minutes for any other final questions. So why don't we get started with the first one, which is paper number 17, initial clinical outcomes of robotic dissection, very high level carcinoma. is it effective? And the presenter is Cliff Libet. And discusses is Julie.
So initial three thoughts for robotic resection. Figure how everything is it effective? Just a brief thing. Two authors, particularly our PIs, Dr. Ross, Dr. Rosemary, and our team. Yeah, this project. So brief introduction. So very high cholangiocarcinoma, as we know, it's an aggressive cancer with a high rate of recurrence. The best chance for long-term survival in these patients is resection with primary tumor. The purpose of this study was to assess the safety and feasibility of short-term and short-term oncologic outcomes of patients undergoing robotic very high carcinoma. So inclusion criteria will be evaluate patients over a 6-year period, 2016 to 2022. And they were all patients who underwent robotic resection for suspected very high cholangiocarcinoma. The reason I say suspected is that actually of the 26 patients that we evaluated, 23 did have cholangiocarcinoma, but 3 actually had a gallbladder primary that involved the confluence of the common hepatic, cystic, and CVD. So we did include those patients because this was kind of a perioperative evaluation study, but and it's essentially the operation was performed technically the same. So jumping into our results. So our median age of patients was 72, majority being male, with a BMI of 28. 15% of our patients did undergo neoadjuvant chemotherapy with GEM and CIS. And at our institution, we try to have patients with a bilirubin less than 3 prior to going to the operating room to optimize hepatic function for any possible concomitant hepatectomy. So we had 88% of our patients undergo preoperative biliary decompression, and 20 of those 23 patients also had a ERCP biopsy at that time. Intraoperative, our median operative time was 464 minutes. Estimated blood loss was 150 milliliters. Of the 23 patients that did have cholangiocarcinoma, we broke them down into different classifications: 5 type 1, 5 type 2, 11 type 3, and 2 type 4. 21 of our patients required concomitant hepatectomy, 7 left, 11 central, and 3 right. And then we had 0 intraoperative complications and 0 conversions from robotic to open surgery. Our oncologic variables we evaluated were lymph nodes harvested and also lymph nodes positive. Our median harvested was 5 and median positive was 0. So kind of the standard across the field is 6 is kind of debated between 4 and 10. There's no hard recommendation from HACC in terms of this. So actually we partway through this evaluation, we sat down kind of noticing this 5 number and sat down with our pathology colleagues and kind of said, hey, what's going on here? And so we actually changed the way we send our samples to PATH now. And instead of sending larger samples with groups of lymph nodes at a time, we individually label samples one at a time and send them in. So that happened over just the last few patients in this series. And it actually increased our lymph node harvest yields on the final pathology report 1.5 to 2 times. So it's not really representative in many of the earlier patients in the sample, but it is moving forward as our experience continues to grow. Our margin status, so 85% of our patients had an R0 resection. However, so that leaves 4 patients with an R1. 2 of those patients who had R1 were actually R0 frozen and converted to R1 upon the final pathology. And as I've been saying, 23 patients with primary biliary adenocarcinoma and 3 with gallbladder primary. So we did kind of do a little sub-analysis of each type of business classification in addition to the gallbladder primary to see if there's any intraoperative variable difference between operative time EBL, and then also the oncologic status is of margin of lymph nodes harvested and biopsy. So this is obviously a small sample size. So it's just in our initial experience, we don't see any issues with a specific type of class having a significant difference from the others when it comes to these variables. So postoperatively, we had 5 postoperative complications. Our median length of stay was 5 days. We had 3 patients readmitted within 30 days, and we had 1 90-day mortality. Upon analysis of this study, we had 18 patients who were alive without any evidence of recurrence. We had 2 patients who were alive with recurrence, and unfortunately, we had 6 patients who had died. So we did want to take a brief moment to look over some literature when it comes to this. So there was a recent study in 2022 that progressive sport matched laparoscopic versus open radical resection for hilar cholangiocarcinoma, and they showed no kind of difference between perioperative outcomes when it comes to these 2 approaches. However, we took some interest in the length of stay numbers. So there was no significant difference that they found between laparoscopic and open, with the median for laparoscopic being 11.5 days and 14 days for the open group. So we just wanted to kind of juxtapose that against our robotic approach that yielded a median of 5 days. And next to those, you can see the interquartile ranges. So we were able to do a direct analysis, but it gives a general idea of where each are headed. So kind of in conclusion, this study supports our hypothesis that robotic resection of perihilar cholangiocarcinoma is safe and effective when undertaken by experienced robotic hepatobiliary surgeons. For experience so far, business classification has no significant difference in the perioperative outcomes. And then also length of stay could potentially be a point where patients could really reap the benefits of a robotic approach versus laparoscopic and open techniques compared to what we saw in the literature. So future directions. So obviously continue to grow our experience of robotic perihilar resection of cholangiocarcinoma. About 50% of our patients, even though this is a 6-year study, 50% of our patients were done in the last 2 years. So the more we get used to this and the more patients we see and we feel comfortable, the more patients we can do and continue to grow. Continue to investigate further oncologic benefits of the robotic platform. So that could be anything from there's been several talks that include lymphadenectomy, higher yields with the robotic approach versus laparoscopic, and then also creating multi-institutional collaborative studies with expert centers for larger cohort analyses, because this is not an operation that's being done very frequently. So continue to work with some other experts in the field that we can pool our data and try to make some inroads on if this is going to be a viable and even a preferred approach possibly in the future.
All right, thank you very much.
I have time, some chance to have a look at it. Just wanted me to go back to 2 small points in the presentation. The first one is with regards to the oncologic outcomes. You did report about 18 patients alive without disease and 2 alive with disease at the end of your follow-up, which means that about 6 of them, so close to 25% of your cohort died following surgery. So I was wondering if you can comment a median follow-up in that series. And the second piece is more about future perspectives with regards to robotic platform. You mentioned it a little bit in conclusion, but how do we foresee potential oncological benefits truly from the robotic platforms versus laparoscopy, or is it a minimally invasive aspect? Like, is there something about robotic that is different than all other approaches with regards to the oncological benefits specifically?
Yes, perfect. Thank you so much for those questions. So in terms of the first one, so our median follow-up time of our patients was about 27 months. And then moving on to number 2. So there was a study recently that Dr. Wadi, I know she's here floating around somewhere, but their group put out that compared robotic versus laparoscopic versus open lymphadenectomy for biliary cancers. And they actually showed that when trying to reach the benchmark of at least 6 nodes harvested, that robotic was superior compared to laparoscopic and open. So that's just one area that we're looking at, because especially in this perihilar cholangiocarcinoma, the understaging is dramatically decreases chances of survival. Anywhere from 5-year survival, there's been a paper I was looking at about 55% with R0 and 0. And then if any T or any R status with N1, it dropped down to less than 20. So that's what we're kind of thinking.
So to follow up, I would maybe, as we carry on, just sort of challenge this a little bit, because in college carcinoma, we all know that nodal sampling or nodal harvest is actually therapeutic. Is a staging approach, so it's stage migration, right, that you're describing when you see changes in survival based on nodal status, depending on how many nodes were harvested. So it doesn't assume there's oncological benefit, or be a little further hypothesis generating work to be done in this area.
I'm Ryan Rush from Minnesota. You have an interesting array of bismuth molecular classifications. I think a lot of people that do this kind of work find more 3s, 4s in their practice, and this was kind of an interesting mix. So can you comment on that for one? And then the second thing I was to say is, with that in mind, it seems like you did a lot of hepatectomies, maybe even for patients with classification 2 anatomy. Was that just noting maybe happening after the fact and realizing that you did it, you maybe didn't need to, or was it planned as part of the operation one way or another?
Yeah, so in terms of that aspect, I'm not a student. I do not necessarily have the perfect answer for you. I know Dr. Sufani, my PI, is here to maybe able to offer the answer.
Thank you for the question. So, as you know, in transcript, it's difficult to really know is it transcript 3 or 4. You know, sometimes you make an intraoperative discovery, even on the preoperative, the best imaging. I don't care what the best imaging is, but many times you think it's 3A, it's not 3A, it's 4. So some of these patients end up classing 3, 4. It's like a retrospective diagnosis after the resections. So our policy is obviously we try to go after the secondary biliary radicals to resect them. For patient with a Tuscan 3, so for example, a 3A is going to be right protective with the M-block. 3B is also left protective M-block. I always take up the 6. So the 1 and 2 not necessarily needing a central resection. But you know, this class, if you do a lot of disease, they are not like a clean cut between 2 and 3 or 3B. Sometimes they are kind of like there is a between stage, and in those patients when there is a concern that there is abnormality in a caudate, then caudate is coming out. Thank you.
All right, thank you. We're gonna move on to the next.
So February 18 is trends in received adjuvant therapy and impact on survival and biliary tract cancers. The presenter is Dr. Kristen Roden from Duke, and the discussant is going to be Dr. Sakolami from Northwell.
Thank you for the opportunity to present our work. Surgical resection remains the foundation of curative intent treatment for biliary tract cancers, or BTC. Despite optimal oncologic resection for BTC, patients remain at high risk of recurrence, and poor outcomes have prompted exploration of adjuvant therapies to reduce this risk and extend survival. The BILCAP trial is a randomized patients with resected BTC to adjuvant capecitabine or observation. And investigators reported a survival benefit with adjuvant capecitabine in their per protocol analysis. These results have been considered practice changing, and national guidelines now recommend adjuvant capecitabine for resected BTC as standard of care. Given these shifts in management, we aim to characterize trends in the utilization of adjuvant chemo among this population and evaluate its impact on survival. Our hypothesis was that utilization would be increasing and be associated with better survival. To do this, we performed a retrospective analysis of the NCDB, querying for patients with resected past stage 1 through 3 gallbladder cancer or intra-extrahepatic cholangiocarcinoma diagnosed from 2010 to 2018. We excluded those with metastatic disease, those who had 90-day post-op mortality, those who had received radiation or neoadjuvant chemotherapy or liver transplant. We also excluded those with stage 1A gallbladder cancer. Our primary outcome was trends in receipt of adjuvant chemotherapy overall and stratified by disease type and stage. And secondary outcomes included factors associated with receipt of adjuvant chemotherapy and overall survival. Altogether, we identified over 7,000 patients, with 31% of these receiving adjuvant chemotherapy. We saw an increase in adjuvant chemo during the study period from 23% of patients in 2010 to 41% in 2018. We saw increases across each stage of disease shown in the figure to the left, as well as by disease type as shown in the figure to the right, with the greatest observable increase in those with intrahepatic cholangiocarcinoma, increasing from 18% in 2010 to 52% of patients in 2018. Patients receiving adjuvant chemotherapy were more likely to be younger and have more recent year diagnosis. These patients also had lower comorbidity scores and were more likely to have private insurance. Patients receiving adjuvant chemo were more commonly treated at academic centers and were more likely to reside in areas with high rates of high school completion, as well as areas with greater median income. Patients receiving adjuvant chemo had larger median tumor size. They were also more likely to have positive nodes and margins on resection, as well as poor undifferentiated tumor grade and ultimately past stage 3 disease. We conducted a multivariable logistic regression model adjusting for demographics and tumor characteristics. And in this model, we found factors associated with receipt of adjuvant chemotherapy to include more recent year diagnosis, female sex, private insurance, treatment in an academic center, and increasing education status, as well as greater disease stage, positive margins, and having extrahepatic cholangiocarcinoma compared to intrahepatic to be associated with the receipt of adjuvant chemo. Alternatively, factors associated with reduced odds of receiving adjuvant chemo included increasing age and comorbidity status, as well as having gallbladder cancer. Overall, median survival in this cohort was nearly 40 months. And when stratifying by receipt of adjuvant chemo, in our unadjusted analysis shown to the right, you can see that median survival for patients receiving adjuvant chemo was 36 months compared to 41 months in the observation group. We conducted a multivariable Cox proportional hazards model adjusting for demographics and tumor characteristics. And here, adjuvant chemotherapy was not associated with a reduction in mortality. However, we did identify a significant two-way interaction with disease type, suggesting that the impact of such therapy does vary by disease site. Therefore, we conducted subgroup analyses by disease type. And among those with intrahepatic cholangiocarcinoma and gallbladder cancer, adjuvant chemotherapy was not associated with survival. However, among patients with extrahepatic cholangiocarcinoma, adjuvant chemotherapy had a significant association with survival and a reduction in mortality. Overall, adjuvant chemotherapy remains utilized in the minority of patients, as suggested by our study. We identified several patient, tumor, and center-specific factors associated with the receipt of adjuvant chemo, and across all comers with BTC, adjuvant chemo is not associated with better survival. However, we report a meaningful interaction with disease type and a 22% reduction in mortality for those with extrahepatic cholangiocarcinoma who received adjuvant chemo. The increasing but low utilization of adjuvant chemo for BTC likely represents the lag of implementing new guidelines, as it's been estimated to take up to 17 years for adoption or practice-changing trials and clinical innovations into everyday practice. In this case, BILCAP finished accruing in 2014, but results were first presented at ASCO in 2017. While BTC are often grouped together in studies due to their similar histologic origin and low prevalence, their management and disease biology differ greatly. Indeed, we observed differential associations with receipt of adjuvant chemo and overall survival based on disease type. Subgroup analyses within the BILCAP trial demonstrate a trend towards better outcomes with capecitabine and lower common bile duct cholangiocarcinoma. However, there were only 80 and 76 patients in each arm with extrahepatic cholangiocarcinoma, and these subgroup analyses from BILCAP are likely underpowered to detect meaningful differences by disease site. A similar trend was observed in the PREACH-12 trial, which had an even smaller cohort of extrahepatic cholangio patients. Overall, there are several limitations to this study, notably their selection bias for which we cannot fully adjust. While the NCDD is a robust data set, there are unmeasured confounders and lack of granularity in several areas, particularly with classification of hilar cholangiocarcinoma, which is vague and was not further differentiated from extrahepatic cholangio in this study. Further, we cannot identify specific chemotherapy regimens and cannot assume that all patients received capecitabine, which limits the external validity. And finally, the latest NCDD data available at the time of this study with survival for patients diagnosed in 2018 at the latest, and we likely underestimate utilization of adjuvant chemo in 2023. To mitigate these limitations, we performed a multivariable analysis, adjusting for confounders and incorporating interaction terms. And our large sample size did enable us to perform subgroup analyses based off those findings. Despite the aforementioned limitations, this is one of the largest studies to characterize contemporary trends in adjuvant chemo for resected BTC, and we hope it can serve as a benchmark for future studies. In conclusion, utilization of adjuvant chemo for resected BTC remains low, but is increasing. Contrary to BILCAP and acknowledging the limitations of our study, there was no association between adjuvant chemo and survival among all comers with BTC. But we do acknowledge that BTC are heterogeneous in their biology and outcomes, and we report some utility in reduction in mortality among those with extrahepatic disease who do receive this therapy. HPV surgeons play an important role in referring patients with for additional therapies after resection. And an emphasis on improving guideline concordance with focus on at-risk populations may improve outcomes, especially for those with extrahepatic cholangiocarcinoma. Thank you, and I'll take any questions.
Excellent presentation, so really important. Really you and as well as obviously the group for asking really important questions. I think just two comments in general is that, using the NCDB, obviously, is just very limited, as you fairly point out. And I think that not knowing what type of chemotherapy is used, also excluding the group with radiation, I would argue that there is actually a public trial, right? SWACO 809 that shows some benefit from adjuvant chemo radiation. And those patients actually received chemo radiation plus chemo in the setting of positive info. So I think I would, two questions that I have for you is, what do you attribute the increase the adjuvant received chemotherapy, even despite a lack of any positive trial? I mean, you are basically presenting all the data before BILCAP is even right. So what are your thoughts on that? Two, what are your thoughts on regionalization? Those sort of in terms of like actually increasing the
Yeah.
access.
Yeah, so with your first question, in talking with senior authors, as well as some of the medical oncologists on our paper, even though BILCAP was not published till 2019, it was presented and the results were somewhat aware of in the medical community. And it sounded like they were already starting to use this regimen before its publication. And in general, the increased interest in improving outcomes on those patients, I would suspect led to this increase earlier than we would expect. And given those limitations of the NCDB, you're right, this is, or we would expect to see such an increase from BILCAP itself. But hopefully this can be a benchmark for that study in like 5 years.
Yeah, I would actually really recommend redoing this in like 5 or 10 years, literally and ask for that. And even on a larger scale will be much better if you really have prospective sort of a registry even trial, because I think the issue with NCDB also not having RFS, in the secondary analysis that we just recently published on SWOG, the differences you saw was actually the metastatic recurrence and by different sites. So you won't have that data available here. So you could be potentially really missing some significant effects. And we did also show in that study that the extrahepatic disease group was a really subgroup. So I do think there's truthfully something here, and it's hypothesis generating. What do you think about regionalization and sort of, in that aspect? Obviously access to care is an issue and how we can improve, but assume in the perfect world, this was, after BILCAP and you're showing that this is the lack of, access to those patients. What are your thoughts on that?
I think a lot of that stems from education in the community and making sure that patients get referred or at least evaluated at tertiary care centers, so that medical oncologists in the community can provide them that care, even if they're not necessarily traveling for it. But I think there is, as this shows, a long way to go.
Very nicely done. So congratulations.
I might ask one. If I read your data correctly as you presented it, you demonstrated that the cancers that were more poorly differentiated or got more chemotherapy. Then in the end, you claim that they do the same. So doesn't these data interpreted suggest that we are making a difference with chemo?
Yes, so in our unadjusted model, we actually saw that those with chemo did worse, but I suppose I would hypothesize that it's because they had worse biology based off the demographics and characteristics we saw. When we adjusted for grade and stage, as well as tumor size, there was no association with mortality. Suggests that when controlling for those factors, they might have done better. They're not doing worse.
It is complicated to look at these old
Yeah.
databases and try to really sort out the meaning, and that was kind of. Thank you very much for your talk. Move on to the next talk now. Cystic duct stump resection as treatment for post-cholecystectomy syndrome. The presenter is Ryan Grosh.
Thank you for having me in this forum. I'm Ryan Greschel. I work in Duluth, Minnesota. I'm adjunct faculty at the University of Minnesota. This will be a more lighthearted talk as compared to many of our cancer discussions. I have no disclosures to make. I'm not sure if anyone in the audience has actually heard of cholecystectomy. I wasn't aware of it until I was a fellow, but it's defined as the persistence or continuation of the GI symptoms of right upper quadrant pain or whatever it was that led a patient to get a cholecystectomy in the first place. And it's certainly something that HPV surgeons and general surgeons may deal with on an anecdotal basis. But it's taken seriously by some authors. And in a Scandinavian survey of 150 consecutive cholecystectomy patients, they found that 5% of these people continue to have chronic symptoms of right upper quadrant pain or postprandial bloating that don't resolve with the operation. And those patients were subject to an exhaustive workup with cross-sectional imaging, MRCPs, endoscopic ultrasound, ERCP, oftentimes finding no exact reason why they continue to have these chronic symptoms. I got the pleasure of seeing Mike Kendrick take out a cystic duct stump and some gallbladder clips at Mayo Clinic when I was a fellow. And I thought, what are we doing here with this operation? The GI group at Mayo had actually been very interested in the concept of the possibility of neuromas forming at the cystic duct stump resection line. And so two of the therapeutic endoscopists there were routinely taking patients with chronic right upper quadrant pain, born EUS with light sedation, and they would actually poke the clips, the cholecystectomy clips with their EUS needle and try to elicit pain from the patient. And then they would also inject steroids and local anesthesia at the site of the clips. And if they either elicited pain and while poking the clips or caused some sort of pain improvements after injecting the local anesthetic, then they would refer the patient to a surgeon suspecting that the patient had a neuroma. And they had found that a couple of times in their series. And they published, this is Mark Topazian's paper from 2005. This was basically outlining the first 3 patients that they had looked at this way. And they haven't published again on it since, mostly because they feel like their data is widely discordant. They don't do a great job of predicting who's going to benefit from potentially having the clips removed. And then my own experience in practice, I finished fellowship in 2017. And, as an HPV surgeon, some of you may also get referrals like this where a patient has chronic right upper quadrant pain after a cholecystectomy. And lo and behold, they have a small remnant gallbladder with stones, or they have a stone stuck in their cystic duct stump. And I would take patients to the operating room and take out their stump, and oftentimes they felt better. And that seemed like a pretty solid indication for returning to the operating room. And then in March 2020, my form of a pandemic with this begins. Our allergy specialist at our center sends me a woman who has chronic right upper quadrant pain 10 years after a cholecystectomy. And she and he have been looking through case reports of patients with metal allergies and needing their cholecystectomy clips removed. And so she was sent to me for that reason. She'd had an exhaustive workup both in Rochester and in Minneapolis, as you can see, many imaging studies, multiple endoscopies. And when I saw her, I said, well, ma'am, I'm not just going to take your clips out. You have no metal allergy testing. I don't necessarily want you to do that, though, because I've seen case reports of the neuroma, the cystic duct stump, And also just with my own experience operating on patients, oftentimes there's microlithiasis in the cystic duct stump that may be sort of underappreciated. And so I said, if I'm going to take you to the operating room and take these clips out, I'm not just taking out the clips. I'm going to take out your entire cystic duct stump. So the area I've outlined in red, we're going to remove all the neurolymphatic tissue to the right side of the common bile duct. I'm going to take the entirety of your cystic duct stump. The clips will come out. I'll deal with your cystic artery through sequential application of cautery or using something Thunderbeat. And this patient felt immediately better as soon as she woke up, walked out of the PACU, super happy customer. And so this same allergy specialist sent me 4 more patients in rapid succession, people with chronic right upper quadrant pain after cholecystitis. And so I had to think a little bit about this. The first patient obviously had been exhaustively worked up, but if I'm going to start doing this more often, I need to make sure that everybody's had some form of good cross-sectional imaging between their cholecystectomy and now. And I at least wanted these patients to get an EGD. When I met them in the office, I actually offered all of them to go down to Mayo for one of these endoscopic evaluations, but all of them turned me down. And the technique which I've sort of described when I did these cases was to use 4 or 5 millimeter ports, or maybe an 8 millimeter port if the bulk of the duct was bigger. My assistant Megan, who's in the room, she actually works on the left side of the patient for these, holding up the liver bundling while I work on the right. We do an adhesiolysis in the subhepatic space. We start distally on the common bile duct, work our way up along its right side, find and pass the origin of the cystic duct stump, and we work to get the clip wad and scar off the liver. And like I said, we divide the cystic artery. I've been using endoloops to control all these ducts because these patients inherently come to see me with concerns about persistent foreign material in the body. And so I have to make some sort of acquiescence to that. So I use a suture that will dissolve. And the specimens are removed either right through the trocar or with a 5 millimeter endocatch bed. And so the first 20 patients that I did like this, they were all outpatients. They all went home the same day. 18 of these patients were women. You can see the age range there. I had no complications in this initial 20 patient set, but since then I have injured one guy's common hepatic duct and left T-tube. And the amazing thing about this is I haven't sort of had to build a practice in this. It's people just keep coming to my office because 18 of these 20 patients feel markedly better. And what I've learned through the process of meeting these referrals is that there is a pretty broad Facebook and Instagram network of patients that are experiencing post-cholecystectomy syndrome, and we just don't really know about it. They've probably seen their PCP or a gastroenterologist and had a normal CT scan, and they just get brushed to the side. But some of these patients, it's like I have revolutionized their life. And so even though I hated doing this at first, I've kind of grown to enjoy it because there is a significant amount of patient satisfaction. These are some of the pathologic findings, and these are not necessarily exclusive. Some patients have more than one finding, and a few patients have had none of these, but half the patients have what's described as a common chronically inflamed cystic duct. 8 of the 20 had an aroma, or what they describe as most of the mass of tissue at the end of the cystic duct is disorganized neural tissue, microlithiasis, the giant cell foreign body reaction. One of them had a hyalinizing granulome. This is not going away from me. This isn't something I asked for. This is something that's just happening. So initially, like I said, it was my allergist in Duluth. But then I had a woman ask to come see me from Minneapolis, and I've had people from out east. And I have a guy from Massachusetts that wants to come out and see me. And I said, why don't you just find someone in Boston? There's people certainly capable of doing this, and he wants to come. I don't want to confuse what I'm talking about with patients that may have chronic right upper quadrant pain that could potentially be associated with sphincter body dysfunction. So we're cognizant of that. I have a great therapeutic endoscopist in Duluth. Oftentimes when I'm reviewing these patients, I look at the imaging with him or bounce it off of him. For patients that do have excessively dilated common bile ducts after cholecystectomy, or if they have persistent liver function test abnormalities, you have to at least wonder whether or not sphincter body dysfunction plays a role. And we have had some of the patients go through an endoscopic sphincterotomy first, and then this patient subset as people who obviously didn't prove with that. And some of the questions to me that this work raises is, number one, am I just seeing a placebo effect? I mean, we've all taken patients to the operating room to do anesthesiolosis, and you go in there and there's nothing to lyse. And they feel magically better afterwards, and so is there just some magic placebo undergoing an operation? And so should I get some quality long-term surveillance of these patients with quality of life and symptom surveys? We may be trying to use some of the free NIH tools for the pain interference scale that will be baked into our Epic platform. Should we consider doing a trial of sham surgery? And then the bigger question is, should we entertain doing laparoscopic cholecystectomy potentially differently? Because I don't know, like I said, I don't know if these people have a clip allergy. I don't know if these people have some kind of microlithiasis in their duct causing chronic pain. And I don't know if these patients have an aroma until I've taken it out, and I can't think of a way of really discerning that frequently. So obviously this is a small sample size. This is just one surgeon at one institution. The way I've obviously reported these self-reported outcomes is highly subjective, but nonetheless, it's been pretty striking. And I lack a true fundamental understanding of why these patients had pain to begin with, and now I seem to feel better. And it's really highly presumptuous to take a poorly understood problem like post-cholecystectomy syndrome and try to distill a potential solution into an operation that probably none of you have ever really considered. With that, I'd be happy to review these conclusions, which are really just to raise awareness that post-cholecystectomy syndrome seems to be a real problem. Just be aware of it. I'm not saying we need to revolutionize the way we do cholecystectomies, but some food for thought. The effectiveness of this operation seems promising in early work, and be open-minded to the idea that the way that you do this standard operation might benefit from some adjustment in the future.
All right, let's open some discussion. Dr. Harnett.
Thank you so much for your presentation. I find it very courageous to take on these types of patients and then to present it and share it with everybody here. You know, when I initially read the title, it generated mixed feelings in me. I'm sure it probably did in the audience as well. But then as I reviewed your slides after I talked to you, I saw that all this really came out of a place of compassion and, you know, listening to patients that have largely been written off, you know, at this point. So thank you for doing that. It's also very challenging to take on patients that you are really going to largely rely on subjective data for your outcomes, at least initially. And hopefully we get to a point where you can get to something more objective. But I do think we're all going to have to learn to incorporate that. And the president said at her morning address, we're all evaluated on core data, non-scientific data, very subjective measures. And we're going to have to find a way to deal with it. You're right, social media is not going away, and we're going to have to learn how to better apply this type of data into our practice. I had a couple of questions. One, did you see any commonalities intraoperative findings wise? You know, because again, I think it would help to disseminate the info if we had something objective to go by. So was there any, you know, was there severe inflammation or adhesions, a longer cystic guts where they absolutely all, you know, clipped? Or had there actually been any patients that had an endoloop originally? And then, you know, is there any way to kind of test for this metal clip allergy before or after fact?
Those are great questions. Thanks. The first thing I'll say is that many of these patients, as you notice, were women, and a lot of them, you know, are younger in the cohort. And so I frequently will just sort of examine the peritoneal cavity of them in there. A few of them have explicitly asked about endometriosis, and so I try to look for that. As far as other intraoperative findings, no. I mean, some of these are more difficult operations than others, as you can imagine. Some patients have no adhesions and some patients have extensive adhesions. As far as the clips and commonalities in the patients, all 20 of these patients had some form of clip. 19 were metal, 1 was plastic. None of these patients had an endoloop closure or some other sort of dissolvable product that ultimately led to this. But that's really a vast minority of cholecystectomies that are done across the country.
Hello, Steve Cunningham, from the section of Cincinnati, Baltimore. Mr. Gross, I just want to congratulate you for presenting this and also for your very honest limitations. I love that slide. I've actually had 3 patients who overlap with this. One who had a metal allergy. And had actually had orthopedic hardware removed maybe a decade before, after extensive allergy testing, and remarkably felt better. And then she got a full cystectomy, not realizing that metal clips were placed, and had recurrence of symptoms and couldn't figure out why, because she thought she had no metal. And that way she gave us this speech from her allergist, who actually did metal testing, and she had documented allergies to nickel and so the metals are in the clips. And then I also had a cystic duct, remnant cholecystitis. And an aroma that got so big that the third patient was an aroma that got so big it caused actually a biliary obstruction as well. So it really does happen. In fact, I think the post-cholecystitis syndrome ratio here from Dr. Hughes talking in a few minutes is probably a lot higher than 5%. I think it's about 40%. But yeah, it's close to food is so common. I think this is a underappreciated problem.
And to your point about metal allergies, there is another surgeon in Texas that is very commonly mentioned in these Facebook groups. But I believe, and I've never been able to speak to him personally, although I've reached out, he actually makes patients get metal allergy testing and only takes their clips out if they have a positive test. The problem I have with that is I don't necessarily think that all of this is clip evidence. Like I said, I think there's some other really plausible explanations for why people have chronic pain.
Like in your plastic patient, was there an aroma there? You remember?
So actually, the plastic clip patient was just a chronically inflamed gut. That was an interesting case because that was a woman that had asymptomatic choledocholithiasis, got an ERCP, had a cholecystectomy, because she still had a gallbladder full of stones, and that didn't have the chronic pain until she woke up from her cholecystectomy. So she was asymptomatic to begin with.
And anything's right with the placebo rate.
Matt Walsh from Cleveland. I think this is a great paper, should be congratulated. It raises several questions. How many of these 18 had calculus disease or acalculous disease in their original cholecystectomy? Why not change your practice as someone who routinely does endoloops for everybody? I think it's great. There are many reasons to do it. And who won't you do?
You mean for this? Yes. Okay.
Who comes with chronic
Sure.
post-cholecystectomy pain? Who's not a candidate?
Those are all good questions. Almost all of these patients were acute cholecystitis as their initial presentation. There were 2 patients that saw surgeons for elective cholecystectomies in the office, and 1 patient, like I said, with choledocholithiasis. I have changed my practice. I use endoloops a lot more now for cholecystectomies, especially in kids. If you have a long allergy list, I mean, frankly, if the patient just seems crazy meeting them, now that I do this, I'm abhorrent of the idea that they come back to my office. Anybody that's had reactions to any jewelry that they wear. So I have changed my practice, and I'm probably moving the way that you are that way. And then your last question, sorry, was just
I'm curious who you won't do.
I don't know. I mean, I think, like I said, if I'm concerned a patient has sphincter body dysfunction. I'll have them get a sphincterotomy first. But I don't know. I don't know how to answer that question. I haven't mentally found a patient yet that I just couldn't handle doing this to.
Thanks so much for that great talk. We should move on to the next paper, which is 20. That is surgical resection alone versus multi-agent chemotherapy alone for localized biliary tract cancers. That be presented by Dr. Mohammed Al-Shami. And the discussing is Dr. Sweden.
Good afternoon. It's a pleasure to be here today, and we'd like to thank the AHA for giving us the opportunity to present our work. Disclosures. The optimal treatment for resectable biliary cancers is the combination of surgical resection and adjuvant chemotherapy. However, as we all know, many patients fail to receive both modalities. So our aim from this study was to compare the long-term survival outcome of patients with localized biliary cancers treated with either modality. So we identified patients with biliary cancers in the NCDB between 2010 and 2017. We excluded patients with metastatic disease and those with unknown clinical stage. We also excluded patients with unknown treatment-related factors such as receipt of chemo, radiation therapy, immunotherapy, and other treatments. We further excluded patients with unknown clinical characteristics such as length of follow-up, duration from diagnosis to treatment initiation, and we ended up with about 9,000 patients. Our primary outcome was overall survival calculated from the date of treatment start. We utilized piecewise constant hazard modeling to estimate the hazard ratios in the post-treatment intervals listed here. We use inverse probability Cox regression to estimate the effect of surgical resection on overall survival and to account for selection bias. We finally conducted a landmark analysis at 30, 60, and 90 days post-treatment to account for the model time bias. We use a directly cyclic graph to determine the confounders to adjust for in our analysis, and these included age, sex, race, education, either income, Chassenday score, health insurance, distance to treating facility, year of diagnosis, tumor location, facility type, and facility volume. Moving to our results, we found that surgical resection alone was associated with an improvement on overall survival as compared to multi-agent chemo alone, with a median overall survival of 36 months versus 11 and a hazard ratio of 0.34. We then stratified our analyses by tumor location as well as clinical T stage, and we found consistent results in patients with gallbladder adenocarcinoma, extrahepatic cholangiocarcinoma, and intrahepatic cholangiocarcinoma. On piecewise constant hazard modeling, we found that patients treated with surgical resection alone had an associated decrease in overall survival as compared to those treated with multi-agent chemo alone in the first month following surgery. However, there was an associated increase in overall survival at 31 to 60 days from chemo initiation for patients treated with surgical resection, and a further associated increase in overall survival beyond that. Similar results were also seen in the IV-weighted analyses that accounted for selection bias. We then stratified our analysis by tumor location, and we found that in patients with gallbladder adenocarcinoma or extrahepatic cholangiocarcinoma, there was an associated decrease in overall survival for patients treated with surgical resection alone within the first month from surgery. However, there was an associated increase beyond 90 days. Among patients with intrahepatic cholangiocarcinoma, there was an associated increase in overall survival for patients treated with surgical resection alone beyond 30 days from surgery. Given the expected short-term survival disadvantage for patients treated with surgical resection, we conducted a landmark analysis with the intent to omit patients suffering from short-term mortality. And we found that using a 30-day landmark, patients treated with surgical resection alone still had an associated improvement in overall survival. And similar results were also seen using 60-day and 90-day landmarks. Like other studies, our study has some limitations. So first, there's a potential of some inaccuracies in data entry and a lack of granular details about the intent of treatment. There's also a lack of data about anatomic, biologic, and patient condition factors that may determine the resectability of the tumor. There's also a lack of granular details about the chemotherapeutic regimens and the chemo cycles and durations. Finally, the NCDB does not provide data on recurrence-free survival or disease-specific survival, which could be of interest to our study group. Despite these limitations, we can conclude that surgical resection alone is associated with improved long-term survival as compared to multi-agent chemo alone in patients with localized biliary cancers, and surgical resection is associated with a decrease in overall survival within the first 30 days of treatment initiation, but with an increase in overall survival beyond 90 days. Thank you for your attention. I'm happy to take questions.
thank the HPVA for allowing me to discuss this nicely presented study. So surgery still remains the treatment of choice for bile duct cancer. That's good to hear. The interesting part is, we compared chemotherapy alone versus surgery alone in this large group of patients from the NCDB. Unfortunately, with bile duct cancer, it remains pretty chemo-refractory disease, as we know, and the BILCAP study recommends capecitabine as the treatment choice for adjuvant therapy for resected bile duct cancer and the metastatic disease. We're talking gemcitabine and cisplatin as the treatment choice, but a recent study showed that the triplets of gemcitabine, cisplatin, and nab-paclitaxel did not do better than gem and cis. So more chemotherapy is not necessarily better in this disease. The obvious question is, what was the patient selection? Or, for instance, what's the performance status of patients who were selected for surgery versus those getting chemotherapy? Because performance status is, of course, an important predictor of outcome in cancer patients. I don't know if you can get that from the NCDB or not, so that's an important question in these patients. Another important question is, did you have any other data? Obviously, you tried to match the stage of the patients between the two groups. Is there any other data such as CA99 levels in these patients? Because that's been shown to be a potentially prognostic factor. Was that available in the NCDB or not? And what do you think would be the ideal regimen? So, over the time frame of this study, what do you think would be the ideal chemo regimen that was selected or used by people who submitted data to the NCDB? And then in the future, do you think that since we've known more about the genetic mutations of these cancers going forward, will we find a point in time where we will be able to target genetic mutations in these patients, and then that targeted molecular therapy will be compared to surgery, and will surgery lose in the future? Thank you.
Thank you so much for these great questions. So to start with the first common questions of performance status and CA99, unfortunately, the NCDB does not provide data on that. It would have been very helpful if we have them. And secondly, the NCDB also does not provide data on chemo regimens. However, when we selected the time period from 2010 to 2017, we wanted to actually capture, to the best of our ability, the utilization of anti-aging chemo up to the release of ABC-02 trial. But we cannot, unfortunately, speak about what are the exact regimens utilized. As for the last question, I believe surgery will remain the mainstay treatment for localized biliary cancers. However, that being said, I also believe that target therapy may potentially in the future replace or at least be given with chemotherapy. And there are actually several trials, say for example, the Biliary trial that look at ivosidenib for patients with chemorefractory cholangiocarcinomas and IDH1 mutations. They saw promising results in unresectable or locally advanced cholangiocarcinomas. And there are several other phase 3 ongoing trials like the Phoenix, the Fight 302, the Roof trial. All of these look at FGFR2 target therapy versus standard chemo. But also these were on in patients with unresectable / locally advanced cholangiocarcinomas. So it would be plausible in the future to use some of these combinations of target therapy and chemo in patients with localized or resectable biliary cancers. But surgery is going to be the mainstay treatment. Yes.
Thank you very much. All right, the next talk 21 is spectrum of mutations in hepatobiliary cancers based on searching for DNA analysis. The presenter is Dr. Jenny Jang, and discussing is Dr. Biliary.
Hi, my name is Jenny. I'm the general surgery resident at the Cleveland Clinic. Thank you for the opportunity to present today. No funding was obtained for the study, and I unfortunately have no disclosures to share. But fortunately for our patients, ctDNA is completed by government at no cost and is part of their clinical care. In the event that the test is not fully covered by insurance, patients are provided financial assistance. Circulating tumor DNA is an emerging technology. It's also called liver biopsy, and it's a non-invasive diagnostic and monitoring tool based on the individual tumor gene alteration profile of various solid tumors. And its utility has been demonstrated in colon cancer, colorectal, liver mets, non-small cell lung cancer, breast, and others. Hepatocellular carcinoma and cholangiocarcinoma, as demonstrated by our previous presentations, have the potential for surgical, curative surgical resection. But the role of circulating tumor DNA in these cancers are unclear. Could it be more sensitive for recurrence after resection? And for our unresectable or metastatic patients, could it guide targeted treatment? Thus, the aim of our study was to report the feasibility of ctDNA testing in the surgical setting and the landscape of tumor mutations associated with ctDNA testing in a single institution clinical cohort of surgical patients with HCC and CCA. We did a retrospective analysis of prospectively collected data of non-consecutive patients at our liver tumor surgery clinic with HCC and CCA and ctDNA testing from November 2019 to January 2023. And ctDNA testing was completed per surgeon discretion as part of their clinical care and was not tested at set intervals during this time period. How does ctDNA work? It's extracted from the plasma in 4 test tubes. It undergoes next generation sequencing, sequence testing targeting up to 83 cancer-associated genes. The somatic alterations detected are listed here on the slide, and variants of uncertain significance are indicated as a detected somatic alteration. This test takes about 2 weeks to result. So jumping into our liver patients, we had 34 patients total. 9 patients did not undergo surgery, but 25% or 25 patients did undergo curative intent surgery. 2 underwent liver transplant, 2 underwent microablation, and we had 21 liver resections. Of these, 3 patients had pre-operative testing only, 2 of which were our liver transplant patients. 5 had both pre and post-operative testing, and 17 had post-operative testing only. 85% of our patients had somatic alterations detected, and the most common somatic alterations detected were TP53, TERT, and ETM, which is frequently cited in the current literature. Of the patients with post-operative ctDNA testing, 27% were negative, and they continue to have no recurrence at time of review. However, 73% of our patients were positive, and the median time from surgery to post-op test is 102 days. Of these, 43% of patients are noted to have a recurrence, and the post-operative ctDNA collection was completed after discovery of recurrent HCC, except in 1 patient who had a positive ctDNA 44 days before detection of the recurrence. 56% of our patients with positive post-operative ctDNA have no recurrence at time of review, with the median follow-up time for post-op tests to repeat imaging of 123 days. Specific to our patients who do have a positive post-operative ctDNA, patients who have a known recurrence had an average alteration of 3.3. The most common alteration was seen in TP53, followed by ATM check, EGFR, ROS1, and TERT, listed in alphabetical order. For the patients with positive post-operative ctDNA and no recurrence at time of our review, the average number of alterations was 1.1, and the most common alterations were seen in BACA and KIT, listed here in alphabetical order. For our 5 patients who had both pre and post-operative testing, 1 patient had negative pre-operative ctDNA testing and positive post-operative. 2 patients had remained persistently positive after surgery, and 2 patients were able to clear their ctDNA after surgery, although 1 patient developed small round cell tumor of the lung several months later. Shifting gears now to cholangiocarcinoma, we had 23 patients total, 1 distal, 5 hilar, and 17 intrahepatic cholangiocarcinoma. 7 of these patients did not undergo surgery, either for metastatic disease or neoadjuvant chemotherapy or transplant evaluation. 16 of these patients underwent curative intent surgery, although not all of these patients had negative margins. 8 patients had pre-operative testing only, 4 had both pre and post-operative tests, and 4 patients had post-operative testing only. For these patients, 83% of patients had somatic alterations, and the most common alterations we detected were TP53, ATM, and ARID1A. TP53 and ARID1A are commonly cited in the literature, although ATM is a little bit less frequently noted. For the patients who had ctDNA post-operatively, 1 out of the 8 had negative ctDNA and continued to have no recurrence at time of review. 88% of our patients were positive for ctDNA post-operatively, with the median time from surgery to post-op test of 47 days. Of these patients, 29% did have a documented recurrence, and 71% have no documented recurrence at time of review, with the median follow-up time from post-op test to repeat imaging of 62 days. For the 4 patients that had both pre and post-operative testing, all 4 of these patients were positive preoperatively and remain positive post-operatively. 1 patient did have positive margins, and 1 patient does have a known recurrence at this time. In conclusion, ctDNA is detectable in most pre-op samples, and no recurrences were seen in patients with negative post-op ctDNA thus far. In patients with pre and post-operative testing, 2 out of the 5 patients with liver cancer cleared their ctDNA after surgery, and 0 out of 4 of the cholangiocarcinoma patients cleared their ctDNA, although 1 did have positive margins and 1 does have a known recurrence. Specific to liver cancer and positive post-operative ctDNA, TP53, TERT, and ATM are known frequently altered genes in HCC. For positive patients, positive ctDNA patients with the recurrence, these genes remain to be the most frequently altered. For patients with post-operative ctDNA and no recurrence, less commonly known genes were the drivers. There are limitations to the study. It's small, it's an observation cohort with little follow-up. And we acknowledge that there are different types of ctDNA platforms out there. We need a systemic approach for pre and post-operative testing of ctDNA with serial longitudinal surveillance, and perhaps we've asked more questions and provided answers. However, the implementation of routine ctDNA is feasible in the surgical clinical setting and supported by our oncology co-authors on the study, and we have continued studies underway. Thank you.
Okay, thank you for that excellent presentation, and I appreciate you sending the slides in advance so the meetings like review them. You know, as you've heard today, ctDNA is not a fad. It's a rapidly evolving field. It's going to be an important part of clinical care going forward. And so I applaud you guys for getting some of these preliminary data points so we can evaluate feasibility here. A couple of questions for you. One is did you have primary tumor sequencing to compare for correlation between what you saw in a certain tumor DNA and what was seen in the actual tumor itself? You know, surprisingly, a high number of intrahepatic cholangiomas, you saw no IDH or FGFR mutations, which are commonly seen. And I think having that correlation would be nice to know. Additionally, did you see any correlation between tumor markers? You got AFP and CA19-9 for both of these cancers that you could correlate to. And was there any correlation between that and circulating tumor DNA? And then finally, you know, this is preliminary analysis, excellent data. You know, but where are you taking this next? That's the most important. How are we going to incorporate this in clinical care, and where do you see this going? Thank you.
Thank you, Dr. Wilson, for your questions. So for the first one, whether or not the next generation sequencing of plasma correlated with the tissue, in the literature, it does support that, and we don't have that data right now, but we are working on that moving forward. And in terms of the correlating ctDNA with AFP and CA19-9, we know that AFP and CA19-9 have kind of a low sensitivity and specificity. And our prelim data shows that ctDNA, although has very low specificity, has 100% sensitivity for no recurrence. And so we think moving forward, we'll need further studies to see if ctDNA will be a good combination to detect recurrence. And so coming to your second question, what we're doing moving forward is we're actually going to be collecting ctDNA every 3 months post-operatively to understand how this correlates with recurrence, how long it takes to clear, and whether or not the patients are positive post-operatively for ctDNA need maybe more frequent surveillance to check for metastatic or recurrent disease.
I have a question. So do you see it then primarily being used as part of a surveillance tool, or would you ever see this being used to guide potentially adjuvant therapy of the patients that cleared it of stop, or are those potentially people that would not need adjuvant?
Yeah, so I know in colorectal cancer, they use ctDNA postoperative to guide adjuvant therapy. Our oncologists actually love that our surgeons are collecting ctDNA because it provides them the information they need to determine adjuvant therapies without that 2 week lag time without the ctDNA prior to coming to their office. So I think it actually has utility in both in surveillance and treatment.
Wonderful. Thank you for that great talk. If there's no other questions, we'll move on to the next one, which is 22 is a functional gallbladder disorder interim analysis of a prospective cohort study. The presenter is Kevin Shu and Dr. Carlos Chan is comment.
Good afternoon. My name is Kevin Shu, and I'm a pre-med student currently in my gap year right now in Maryland. I want to thank everybody for the opportunity to present our findings regarding a prospective cohort study of cholecystectomy for functional gallbladder disorder. We have no financial disclosures. So functional gallbladder disorder is diagnosed by the Rome Consortium criteria and defined as the presence of biliary pain and the absence of gallstones and other structural pathology. More specifically, biliary pain, defined as epigastric, and or right upper quadrant pain that's gradual in onset, lasts longer than 30 minutes, severe, episodic and not daily, not related to bowel movements, and not alleviated by antacids or changes in body position. And the diagnosis can be further aided by a low ejection fraction, normal liver panel, and normal amylase and lipase levels. So while cholecystectomy is relatively uncontroversial for symptomatic cholelithiasis, it remains controversial as an operation for functional gallbladder disorder. And as Dr. Gosha was mentioning earlier, as many as 30% of patients, or 35% of patients have recurrent pain after the operation, which is known as post-cholecystectomy syndrome. And post-cholecystectomy syndrome occurs up to 3 times more likely in patients without gallstones compared to those with cholelithiasis, and it's likely underreported. In addition, it remains unclear which factors would select patients with functional gallbladder disorder for cholecystectomy. There's no universal agreement about which indications would predict a successful population. Some surgeons use the intuitive finding of a low ejection fraction, and others use pain reduction upon gallbladder stimulation at the IDA scan. But neither of these is well supported by evidence. In addition, prospective studies are rare. Despite decades of data in the literature and scores of retrospective non-randomized studies available, only about 4 or so studies exist that are prospective, and these are from the 1990s and 2000s. And unfortunately, blinded randomized controlled trials are difficult to design for a number of reasons, including ethical concerns involving a sham laparoscopy. Only 2 randomized controlled trials exist. In 1991, Yap and colleagues enrolled 21 patients, with 11 patients receiving cholecystectomy and 10 patients not receiving cholecystectomy. About 91% of patients receiving cholecystectomy improved after the procedure, although the study has been criticized for methodological issues, as well as testing that has evolved over the past 38 years. And more recently, in 2012, Richmond enrolled 30 patients, with 15 patients randomized to receive cholecystectomy and 15 patients randomized to non-operative arm receiving medical therapy. However, nearly all patients in the control group crossed over to receive cholecystectomy within 1 week. So given all of this, given the lack of evidence, given the difficulty in designing a good randomized controlled trial, and given the high rate of failure with post-cholecystectomy syndrome being reported in up to 35% of patients and being likely underreported, we designed a prospective cohort study that strictly selected patients based on Rome criteria, regardless of ejection fraction or pain reduction at height. And we hypothesized that these patients would yield us with 2 sizable groups, those that durably improved after the operation and those that didn't, which we could then further evaluate to identify characteristics of those who improved to aid with future patient selection.
And this study was done at Ascension St. Agnes Hospital in 2016. Patients with functional gallbladder disorder were enrolled, given pre and post-operative surveys to assess biliary pain and quality of life, and underwent cholecystectomy. Biliary pain was assessed with the rapid rule and quality of life with the SF-12, both of which are well-validated instruments. These surveys were given before the operation and at 3 and 6 month post-op by an independent study member. Statistical tests used included t-tests, chi-square, and Pearson correlations. And with a sample size of 80, the study was calculated to have a power of 82% to yield a statistically significant. So midway through enrollment, however, it was noticed by the independent study member that nearly all patients were reporting improvement. And as such, an interim analysis was conducted after 46 patients were enrolled. The average age was 42. 39 of the patients, or 85%, were female, and most patients were white, with Black being the next largest group at 8 patients. And although none of the patients had stones on rapid ultrasound as part of the selection criteria, 10 of them were found to have stones on final pathology, and these patients were not excluded from the analysis. Of the 31 available rapid tests, 26 of them, or roughly 84%, reported improvement at either 3 or 6 months. And of the 30 available SF-12s, all but 2 of them reported. And unsurprisingly, with these numbers, neither rapid nor SF-12 correlated significantly with the ejection fraction or with pain reproduction at HIDA. And speaking of pain reproduction at HIDA, HIDA scans for functional gallbladder disorder are typically done with either CCK or a fatty meal, which is typically a bottle of Ensure, to stimulate the gallbladder and obtain the ejection fraction. And our group has previously done work looking into the agent of gallbladder stimulation, which found that CCK was significantly more likely to reproduce biliary pain compared to Ensure. Consistent with the intention to treat design of this current study, both of these agents were allowed. And although the current study was not powered or designed to show a relationship between the agent of gallbladder stimulation and pain reproduction, we nonetheless found that Ensure was less than half as likely to reproduce pain compared to CCK, which is consistent with that previously published work. And as mentioned before, and consistent with the literature, despite screening, about 20% of patients were found to have stones on final pathology. And again, as this was an intention to treat study, these patients were not excluded from final analysis. So in summary, of the 70 or so non-randomized studies available in the literature, only about 4 of them are prospective, and these are from the 1990s and 2000s. This is one of the only studies that is prospective, that strictly selects patients based on Rome criteria, and that uses well-validated instruments to assess biliary pain and quality of life. And we found that cholecystectomy for functional gallbladder disorder, which is widely considered to be a controversial indication for cholecystectomy, is nonetheless similar in its success rate to cholecystectomy for cholelithiasis, which is an utterly uncontroversial indication for cholecystectomy. And so therefore our understanding that cholecystectomy for functional gallbladder disorder should not be controversial, at least while the patients are selected strictly by Rome criteria. I'd like to thank all of these individuals for their contribution to this study. In particular, I'd like to thank Dr. Cunningham for allowing me to come onto the study and being an excellent mentor and friend throughout this whole process. Thank you very much for your attention.
Thank you for such a nice presentation. I want to congratulate you for studying here. You said that's a tremendous student. Biliary dyskinesia represents a controversial diagnosis. Having the gallbladder smooth muscle, there is no doubt that in some instances, dysfunction may be the cause of pain. As you mentioned, there is not enough evidence to support the way to diagnose and treat this entity, and represents a very low percentage of the gallbladder disease. In your study, 20% of patients had stones in final pathology. It is of some concern that the indication of surgery is expanding, as you suggest in your conclusions, both for dyskinesia and hyperkinesia. My main concern lies in the probability of severe vital injury, another type of complication of cholecystectomy, certainly low in this country. Series of cases that the evidence we have report that patients benefit from cholecystectomy if the diagnosis is adequately done by Rome criteria. As you mentioned, there's a high percentage of cases with post-cholecystectomy syndrome. This is probably because the origin of the pain was other than the gallbladder, or in other side, some patients may improve by the placebo effect of the operation. The risk of bile duct injury has not to be underestimated, particularly in cases of patients of this type of patients that are usually young and healthy. The repair is more difficult. This is my personal experience and personal communication from Professor Mercado in Mexico. I think this should be an exclusion diagnosis. The questions I have for you is, do you think endoscopic ultrasound can help to select better the patients to operate? How many patients had biliary sludge or cholesterolosis? And did you find the same high incidence of post-cholecystectomy syndrome? Because we didn't see this percentage from your study, the post-cholecystectomy syndrome.
So did we see the same incidence of?
The post-cholecystectomy syndrome. I mean, you said it's high, like 30%, but in this study, what was that percent?
Thank you very much, Dr. Chen, for those kind words and those excellent questions. Regarding the stones, yeah, again, about 20% of patients were found to have stones on final ultrasound or on final pathology. And, you know, even assuming the worst, which is that all of these patients were artificially inflating the improvement, that still would have been about 90% of patients reporting increased quality of life after the operation. More specifically regarding post-cholecystectomy syndrome, again, we found that the majority of these patients, and at a rate that's remarkably similar to that for symptomatic cholelithiasis, did improve. And so our follow-up was, again, only at 3 or 6 months. So we didn't follow up longer, as maybe like in 10 years, maybe these patients would develop, and it would be the case that these patients would develop post-cholecystectomy syndrome. But at least within the scope of this study, the rate of post-cholecystectomy syndrome was much lower at around, say, 10%, which is much comparable to that of cholelithiasis.
Matt Walsh from Cleveland. It's always nice when your bias is reinforced, which is that if you take a good history, you'll be able to figure out who's going to benefit. And so if I interpret this correctly, none of the studies, the injection fraction and the height scan helped. So have you banned the use of those tests at your hospitals now, or at least PCPs from ordering them?
No, I don't think we've done any of that. But again, just because the study was done in an interim analysis, and so obviously we're not at power to draw any conclusions. So obviously we can't say that, you know, that ejection fraction or that height scans isn't helpful in the future. We can only say that in terms of the direction that we're seeing from these numbers, it seems like Rome criteria is the main supportive criteria for selection. And obviously this needs to be validated by a much larger sample size done at different institutions, but that does seem to be a hopeful trend.
I have 2 questions. The first relates to the ejection fraction. So, you know, this was focused on low ejection fraction. What about what's, I think, being increasingly reported on biliary hyperkinesia? So abnormally high ejection fractions. When you correlated to, you know, said there's no correlate to the ejection fractions, where you're just looking at low versus like greater than 80%. That's my first question. The second is, you mentioned the pathologic finding of gallstones, but what else did the pathology show? Because I do a fair number of cholecystectomies for both biliary dyskinesia and hyperkinesia, and I find that at least 75% of the time the path is actually comes back as chronic cholecystitis. So were there any other pathologic abnormalities in your samples?
Yeah, so I can't remember the exact things off the top of my head, but regarding your first question, I believe about 2 patients were found to have biliary hyperkinesia, but we didn't stratify the results by those 2, so I'm not sure if they had differing results in terms of their outcomes. And then with regards to other outcomes, I believe, or other findings on final pathology, I believe there are about 8 disparate things that weren't either a normal gallbladder or you know, gallstones. There was some instance of bloating and some other stranger findings, but I don't believe there was any for cholecystitis, although I'd be happy to look into it and get back to you on that.
I get this comment, and also Dr. Beers, it's a great question. My gut instinct is that, the ejection fraction doesn't really matter. This is why we designed the study to not even consider ejection fraction. Any ejection fraction could enter as long as you met the wrong criteria. But I also see patients with 99 ejection fraction or 1 ejection fraction, and there's still really no good evidence. I kind of mentioned about how that guides us in the clinic. So I don't really pay much attention to it, and especially how secure is the diagnosis for strictly for wrong criteria that they actually have. Biliary pain. And the same thing applies for pain reproduction upon high gallbladder stimulation. There's no good evidence that it helps, although in that case, my gut instinct isn't supportive, but that's just sort of based on gut instinct.
Let's move on to the last talk, please. Targeting cellular metabolism in cholangiocarcinoma. Center is Dr. Syed and discussing is Dr. Winslow.
It's not.
At a 23. That right there?
Good afternoon. I would like to thank the HPPA for the opportunity to present our study targeting cellular metabolism in cholangiocarcinoma using repurposed DTAZN inhibitor. The investigators have nothing to disclose. Cholangiocarcinoma is a rare aggressive cancer with an incidence of 12,000 cases per year in the US. Cholangiocarcinoma can involve any part of the biliary system and is classified as intra or extrahepatic, which includes peripheral and distal. Although cholangiocarcinoma is aggressive and highly resistant to chemotherapy in selected patients, cervical resection remains the first line of treatment as long as R0 resection is achieved. The cholangiocarcinoma 5-year overall survival rate is extremely good. It's 17 to 24% for localized disease and it's only 2% for distant disease, which emphasizes the importance of early diagnosis. In the right-hand side graph, we see the low overall survival rate in intra and extrahepatic cholangiocarcinoma. Histologically, cholangiocarcinoma is unique. It has extensive desmoplastic stroma. In addition, the cholangiocarcinoma microenvironment is frequently hypovascular, hypoxic, and brain depleted. Overall, the tumor-reactive stroma provides an environment that offers tumor growth, metastasis, and chemoresistance. The study aims to repurpose the DTAZN inhibitor as a mitochondrial inhibitor in cholangiocarcinoma treatment. Why are we interested in CDI? CDI was used since the 1940s as an antimicrobial drug in clinical practice, as well as in veterinary medicine. Here we see studies from the 50s and the 60s showing CDI efficiency. CDI was FDA-approved compound, which was used for several decades with a good tolerability and few side effects, which were mainly GI related. In the past, CDI was suggested as an anti-metabolic inhibitor. To assess the direct cytotoxicity on cancer cells, we use cholangiocarcinoma cells treated with CDI and other compounds. In these graphs, we see the dose response curve. 100% is defined as full viability. The blue curve represents CDI, and it shows that it's highly effective in treating cholangiocarcinoma cell line. As a positive control, oxaliplatin treatment was examined for comparison. IC50 is a concentration of which 50% of the cells will die. And in the table above, we see that the IC50 of the CDI is in the sub-micromolar range. To further assess the effect of CDI, we performed a colony-forming assay. In the graph, we see that CDI decreased colony forming in nanomolar range. Moreover, CDI is more effective compared to oxaliplatin. To further assess the effect of CDI, we performed to assess whether CDI has an anapoptotic effect. We completed flow cytometry with annexin and PI staining. In the graph, we see that CDI induced marked apoptosis and necrosis, as we see in the right upper and right lower quadrants in the graphs, in cholangiocarcinoma cells compared to controls. Aside of being strong anti-cancer drug, CDI is known also as a fluorescent compound. Its fluorescence is bright red. Previous reports have suggested CDI as mitochondrial dye in live cells. We wanted to see whether CDI colocalizes into the mitochondria and cholangiocarcinoma cells. For that, we used HESH to stain cell nucleus with blue, mitotracker for mitochondria, and CDI as a red fluorescent dye. The combined pictures show us that CDI colocalizes with mitotracker green, and we have orange stained areas. The mitochondria have an essential role in many important cellular processes, including metabolism, apoptosis, and it's the main source for ATP. Mitochondria have its own genetic system, which encodes for 13 subunits of a ATC protein complex, as we see in the picture. It has two membranes, outer and inner, and the oxidative phosphorylation takes place in the inner membrane, but by creating an electrochemical gradient across it. As the mitochondria are a main source for energy and ATP production, this provides new therapeutic target. Since CDI localizes to the mitochondria, we checked if it has an effect on metabolic function, the oxidative phosphorylation. We did Western blot for oxidative phosphorylation after CDI treatment. We see that CDI caused a marked decrease in the ATC protein expression compared to the MSO. We got similar results when we use oxaliplatin as a negative control. And also protein. We also see that CDI caused a marked decrease in mitochondrial protein expression compared to control after CDI treatment. Our lab has recently shown that pyridinium pamoate, PP, is a mitochondrial inhibitor. Its mechanism of action works through decreasing mitochondrial RNA expression. Following the observed decrease in protein expression in the OXPHOS mentioned in the last slide, we progressed to measure the mitochondrial RNA expression with real-time PCR, which revealed a marked decrease in the mitochondrial RNA expression in CDI-treated cholangiocarcinoma cells compared to the MSO and oxaliplatin. Having seen that CDI kills cells and decreases ATC expression, we quantified the cellular ATP of cholangiocarcinoma cells growing in an glycemic condition that showed significant 100-fold decrease in the ATP production with CDI and other non-mitochondrial inhibitors compared to normal ATP level with control and chemotherapeutic drugs. We are still working to understand the downstream cytotoxic effects of CDI, especially as they pertain to ROS stress and utilization of NDPH and NDH. In the graph, we see that after treatment of CDI, NAD to NADH ratio is almost half compared to DMSO and other drugs. To summarize, cholangiocarcinoma is an aggressive cancer, highly resistant to standard chemotherapeutic agents. Mitochondrial inhibition can potentially allow for an alternative targeting pathway. The previously FDA-approved antiparasitic drug CDI shows anti-cancer properties in vitro and is associated with decreased mitochondrial RNA expression, decreased ATC protein expression, and ATP depletion in cholangiocarcinoma cells. Future plans include to validate our in vitro result in an vivo model, mouse model, with which will compare TDI with other treatments. Thank you.
Congratulations on a really well illustrated talk, and of course, studying a really important topic. I think one thing we can all agree on is the need for better agents in this disease. Just have a couple of quick questions. I know we're out of time. One is tumor microenvironment expected to be different enough in the variants of cholangiocarcinoma, both intrahepatic, extrahepatic, hilar, and also in the different molecular signatures these tumors have, and if that would affect this drug? That's the first fine question. And second, what challenges do you see in going into the in vivo model? And then finally, how did you select this particular drug for study? Was that experimental or based on just prior studies in the paper as well? So thanks, congratulations on this talk.
First of all, for the cholangiocarcinoma subtypes, we know that there are different, like the different cholangiocarcinoma subtypes, like the intrahepatic and periohilar, and the distal have different characteristics, and I think also they have also different microenvironment. That cells like the intrahepatic cholangiocarcinoma, which mainly are in the liver, it's a little bit different than the distal cholangiocarcinoma, which is more close to the instance and the pancreas. So there is a difference between that. For the second question, it's why about the drug selection. So our lab has previously done research with the PPE drug with a premium weight. And there's also lots of publication in the PPE that it's working as anti-cancer drug. And because of CDI, it has a similar structure as a PP. Then we start studying it in the lab. We have tested in multiple models, and also we did already a in vivo and in vitro experiment in pancreatic cancer, and to show that it's really working. And our data about the pancreatic cancer was presented a year ago in the AACR in New Orleans.
All right, thank you, everybody. Thanks for a very exciting session. Appreciate you.